so excited to announce our keynote address. Dr. Yoon Park is here with us today to speak to us about assessment, as we talked about earlier today. Dr. Park is currently an associate professor at Harvard Medical School, director of health professions, education research at Massachusetts General Hospital. Initially got his bachelor's in mathematics and Japanese, a master's in applied statistics, and a PhD in measurement, evaluation, and statistics from Columbia University. He has a very unique background with both academic and industry experience. So he's worked as a senior research project manager, research and development and educational testing service. He's also been an associate professor and also associate head of the Department of Medical Education at the University of Illinois, which is where I think he first met Dion. Has been awarded numerous different honors, including Departmental Faculty of the Year and Rising Star Award, Teaching Recognition Program Award, and currently holds titles such as Chair of the Research in Medical Education Committee of the AAMC and Vice President and Member of Council for the American Educational Research Association. So as we've already talked about, his research focuses on assessment methods in health professions education, and has extensive collaborations across multiple disciplines, so psychometrics, biostats, educational psychology, and medicine. But when I was going through his CV, the thing that was really most striking to me was one, how long it is, how many publications he's managed to produce even over the last year or so. He has books on assessment in health professions education, and some of the titles from recent publications have involved subjects like using computer-based testing to predict residency matching, predicting performance on board exams, looking at assessment of technical skills, and also looking at, kind of reporting milestones-based learner analytics. And these are all topics, some of which have been discussed today and certainly of interest to us in radiation oncology. So I'm just really excited to hear from him and his talk today on measuring competence through systems of assessments, best practices, and guidelines for clinical assessments. So Dr. Park, take it away. You should be able to, yeah, you were advancing. Yep.
All right.
Oh no.
All right. Thank you very much to the ROECSG leadership, and it's such a pleasure to join you at this annual meeting as well. So my presentation is on measuring competence through systems of assessments, best practices, and guidelines for clinical assessments. So in this presentation, I will be going over an overview of assessments, going over some of the scientific principles of how assessments function, what are some of the best practices and guidelines around assessments. And then I will be shifting gears a little bit to talk more about clinical assessments and more so on assessment systems. I will be sharing some examples from my work, but I think they'll have implications for radiation oncology and education more broadly. And then following these examples, I will be going over some guidelines as well as some summaries and next steps for implications. So I'll begin with a very general overview of competence. And around 10 years ago, or maybe more so than that, there was a very nice analogy that several colleagues in the medical education field have proposed, and it's called the T-steeping model. And you may be very familiar with this model as well. This model provides an analogy for how we think about competency-based education in relation to time-based education. So the idea of the T-steeping model, and this is just an analogy, goes like this. So you have a tea bag, and you steep the tea in hot water for a fixed amount of time. After that, you get good tasting tea. And so this analogy has been used in the field quite broadly to refer to time-based education. So for example, we have the learner, which sort of serves as the tea bag, and they're in a program of education, whether it's medical school, residency, fellowship, and so forth, for a fixed amount of time, and afterwards, they're somehow assumed to be competent because of their time-based training. Now, this movement really came about and has really changed some of the ways we assess and we measure performance for our learners and beyond. So what that has led us to begin considering this T-steeping model is to allow us to now think more closely about competence and what it means to be competent. So one way that I think about competence is you have, so here the x-axis is time, the y-axis is performance. And when you have a learner, you have some level of competence that the field, the community has established to be competent. And typically when we think about the pathway of a learner going from wherever they begin to their level of competence, we're interested in whether that learner meets that level of competence, whether they're competent, not competent, ready for unsupervised practice, or untrustable, so forth. So that has been a very interesting set of discussions and interesting set of assessments that were developed to examine whether learners have matched or have arrived at this level of competence. But what's also very important in this discussion of competence, and this is one of the topics that I will be focusing on, is this pathway toward competence, because we know that the learner's progression toward competence may not always be linear in the way that we see here. So they could always also be nonlinear or very nonlinear, as you can see in this example here. So much of the discussion in the field of assessment has shifted not only in examining whether learners or professionals meet this level of competence, but also their pathway toward competence, because the pathway is where we as educators can focus our educational interventions, feedback, mentoring activities, and so forth. And so this middle aspect of where the assessments that lead to competence has become a very important part of the discussion towards pathway toward competence. Also, partly nowadays, people are also interested in whether technology or analytics or different types of feedback mechanism can facilitate this pathway. So this is just one of the motivating slides for my presentation. I will be going over in the next few slides some formal definitions of how an assessment person thinks about assessment, some of the guidelines around assessments, and then we will be talking more formally about clinical assessments, assessment systems, and also pathways as well. So I'd like to begin with a definition, a classic definition of an assessment. And when we begin to ask a question, what is an assessment? There are actually three key components that always characterize any type of assessment. So when we think about an assessment, one of the key principles of an assessment is that an assessment is a sampling question. So you have a bank of behaviors, whether it's types of domains of learning, knowledge, patient care encounters. And the question for the assessment developer or faculty is, how do you systematically sample the types of behaviors that you want in a way that's meaningful? So sampling is always key, and it's always so important because this is what derives the type of feedback that you provide. That's the first thing. Number two to assessment is the type of standardization and the structure that the assessment provides. Any type of assessment, regardless of its format, has some type of structure. So at one extreme, you can think of written tests that have a lot of structure, a lot of standardization. To the other extreme, you can also have workplace-based assessments, assessments that occur in the authentic workplace that perhaps have lesser degree of standardization and structure, but still has some structure because they're still using an assessment form. There is still some rater training that helps enhance the quality of assessment. So sampling, standardization are two key components of assessments. But also what's important in an assessment is this third component, which is you are trying to generalize or make inferences about the learner's behavior that they perform in an assessment situation to a non-assessment situation. So for example, if a learner performs well in the classroom or under observation, you'd hope that that same performance is translated in the real world setting when they're interacting with patients or when they're performing in the authentic clinical environment. And so, when we talk about things like, are these generalizable things? What's the validity? This is the third component where this becomes important. And I like to talk about this assessment components first, because this kind of helps us frame the next 5 guidelines that I'll be talking about as well. Okay, so now I'll be presenting to you about 5 key guidances when I think about assessment before I go into specific examples. The first has to do with reliability. Reliability, very generally, is a concept that's used to talk about consistency in information, consistency in decisions, consistency in feedback that faculty provide. And this is very important when we talk about assessment. So I'm not going to talk specifically about what number of reliability is good enough, but I'm going to talk about reliability in the sense of a very conceptual nature here, because the more items or the more observations that you have in an assessment, the higher your reliability. And this is a very important fact that's important to consider, because this is a mathematically derived truth. So here, this is an example. On the x-axis, you have number of observations. On the y-axis, you have reliability. This is a phi coefficient, is a type of reliability. And as you can see, the more observations there are, the higher reliability. And this is important to consider. And when we think about, how many observations do we need to have a reliable or a consistent workplace-based assessment, or how many stations do we need to have when we design an OSCE, for example, this is where that concept builds in. And this is important to consider. Of course, after you hit a certain point, there is a diminishing return, but this is a key component to consider. Second important consideration for an assessment deals with how well the assessment is able to differentiate or discriminate differences of learner performance. And by discrimination, I talk about the variability. So let me give you an example. So the x-axis here is a range of assessment scores, just very hypothetically. And let's say you have 2 different types of assessments. The blue dots is a cluster. Let's say this is an example of one assessment. The red dots would be a different type of assessment. The difference here being that the blue dots are so clustered that the assessment is not necessarily being able to function, whereas the red dots, you have much more variability. And so you're able to provide much better quality of feedback. Your information that you provide back to the learners has meaning. And so perhaps not all the time, but most of the time when you're developing assessments, you're trying to maximize this variability of your learners. However, we know that in the health professions and medical education, as learners become much more advanced in their training, they become much more homogeneous. So this is what makes developing assessments in medical education very challenging. But fundamentally, this is a very important concept to remember, that we want to maximize as much as we can the variance whenever we're developing assessments. The next aspect of assessments is what we refer to as case specificity. And this is actually very important also consideration, particularly in medical education. And this aspect of case specificity is something that we don't really see in other types of education. So for example, you would not see this in middle school, high school education, but you will see this more so in medical education. And the idea of case specificity is this. So a learner might do well on a specific case, but they may not necessarily do well on another case. And so performance in medical education is very case specific. In other words, just because a learner did well in one case is not a good predictor of how well they would do in other types of cases. And this is also the reason why we have to have a good number of cases, for example, in an OSCE, or when we're observing our learners, we need to have a good sampling of their performance of different types of patient encounters that they would have. And so this notion of case specificity becomes so important, and studies after studies of assessments show evidence of high levels of case specificity in medical education. And this is important to remember as you're designing and blueprinting your assessments. The fourth aspect is relates to gathering information from multiple assessments. So here's an example. Let's say that you have 3 different types of assessments: a clinical examination, an observation, an OSCE, and a multiple choice test. Typically, when we're measuring or making inferences at the competency level, it's really hard to use one assessment tool to make inferences about somebody's patient care abilities or how professional they are. So typically, we'd like to use information from multiple assessments. And there's a good reason for doing this, because when you combine information from multiple assessments, you actually maximize the reliability of these assessments. And again, this also is a mathematical derivation as well. So here again, just some hypothetical numbers. Let's say you're weighting these different assessments by different weights as demonstrated here. And if these different assessments have varying levels of reliability, and we know that clinical observations typically don't have the highest levels of reliability, OSCEs also don't typically have the highest levels of reliability. Multiple choice typically has higher, but may not be as high as you want. But once you combine these, you will have, because of the power of multiple assessments, significantly higher levels of reliability. You may have seen in the literature that there are good reasons to think about programmatic assessment, for example, where you combine information from multiple assessments, or clinical competency committees may use information from multiple assessments. And this is the foundational idea underlying this concept, because you will have higher levels of reliability as a result of combining these levels of information. Finally, so this is the fifth. For a very long time, there's been a lot of debate in the medical education community around the comparison between these two types of scales. So on the top end, you have what we typically call a standard rating scale. So this is a scale, as you see here, where they have global anchors, like critically deficient all the way through to aspirational, or another type of scale that's more behaviorally anchored, or what we refer to as construct-aligned scales. And so there's been many different experiments that researchers have done to test which type of rating scale is superior. And so after many of these experiments, we know that construct-aligned scales have higher validity evidence. And that is probably the reason why the scales that people develop for observational tools tend to have more descriptors. Of course, what this also means is that they're much more resource intensive for rater training, and also take more time because there's much more language to understand. But this is some of the guidance and the science around assessments that's sort of unique to medical education. In the next few slides, I will talk about more specifically about clinical assessments, particularly workplace-based assessments. These are typically assessments that occur in the clinical environment. And they're generally divided into two different types. One is what we call SCOs, or structured clinical observations. And I'll define this a bit further. And then the other, which I'm sure many of you are familiar, is these rotation evaluations. SCOs, or structured clinical observations, are very straightforward. They're basically assessments that deal with direct observations. So if the attending is there with the learner and directly observing the learner behavior, these are called SCOs generally. Now this is different and differentiates with end of rotation evaluations, or rotation evaluations in Canada. They're typically referred to as in-training evaluation reports, or sometimes referred to these as multi-source feedback. These are different than SCOs because they deal with more longitudinal observations. And so they may include not only direct observations, but indirect observations, and they may prolong information over time. So they may gather information from multiple faculty, for peers, other interprofessional staff. So I say all of this, and I'd like to begin with a story that one of my colleagues had asked me about 10 years ago. So about 10 years ago, when I joined the University of Illinois in my previous place, one of my colleagues came to me and said, in graduate medical education, and also in the undergraduate setting, we do so many of these observations, we do so many of these rotational evaluations, and yet when I try to find out evidence around how effective they are, because they're used all the time, I'm not really able to find much evidence. And at that time, there was a momentum towards the milestones, the next accreditation system. And so it was important for us to have a better understanding. So we went about to look at the literature, and indeed, there weren't too much evidence around these rotation evaluations. So we went about to study them ourselves. So in the next few slides, I will be sharing some evidence that our team have gathered around rotation evaluations and building into assessment systems. So these this is actually just an example from radiation oncology for the milestones, as you're probably all familiar. So in the next few slides, I'll be talking more so about rotation evaluations because I think these are so widely used. And I think there are very nuanced guidance that I think will help enhance the quality of our assessments when we begin thinking about and when we consider some of the strengths of rotation evaluations and things that would make rotation evaluations much more powerful and the quality much more rigorous. These are just examples of studies that we've done with colleagues in internal medicine, surgery, psychiatry. We've done this, replicated this type of work in other specialties as well. But they're very similar. And so in the next few slides, I'll be synthesizing some of these guidance. One of the key questions that we were asked by our colleagues for rotation evaluations, because we're collecting information from multiple rater groups, is which rater groups provide more information? And this, for this particular evidence, we looked at over 400 learners, over 7,600 evaluations, and many different types of assessors. So one way to look at different types of rater groups is to look at, there's a metric of variability that we can quantify. And we were able to do this for faculty, for fellows, for advanced learners, and also for peer resident evaluations. As you can see here, the faculty evaluations had high levels of variability or discrimination. So the higher, the better here. And this is in some sense intuitive because faculty will know what to observe when it comes to patient care, when it comes to the specific clinical skills that they want to assess. What was interesting was this gradual decline in the level of discrimination that we have from these different rater groups. So we went about also to look at how similar or dissimilar these ratings were between faculty to the different rater groups. So one of the very straightforward things that we could do was to look at correlations between faculty and fellows, and also between faculty and peer resident evaluations. So these are correlations, they're observing the same person, but there are differences in the information that's provided between faculty and fellows. So between faculty and fellows, we can see that there's moderate amounts of correlation. So there's some alignment, but not too much. And when it comes to residents to faculty, modest amounts of alignment, but not too much. So this allowed us to be very interested in what's going on here. And in fact, what was surprising was that where there was lower levels of alignment was for competencies related to professionalism and for communication skills. And in fact, what we found was that residents and fellows provided much more meaningful information for professionalism and communication skills, more so than the faculty, perhaps because maybe they spend more time with their peers. And so they're able to provide that amounts of rich information for when it comes to professionalism and communication skills. So I'll revisit this finding later on when we begin synthesizing the results, because I think each rater group provides different sets of very useful information when it becomes assessing learners at the competency level. Another important finding that we had was reliability, so we did a comparison of reliability that was just based on faculty only, which was 0.59 for this particular data set. And then when we begin looking at data from multiple rater groups, so multi-source feedback from all of the different rater groups, if we combine that information, so you can see that there's much more superior levels of reliability or much more consistent information once we gather information from multiple groups. One of the questions that one of our coordinators had asked, because the coordinators were tasked with gathering these rotation evaluations or direct observations immediately following the assessment, was, do longer delays affect scores? Because there were some assessors who provided their assessments right after, or there were a few others who took a week or 2 weeks, 3 weeks, some of them even after a month. So we wanted to empirically see, does delays in submitting their scores impact the quality of assessments that we receive? And we weren't able to find evidence of this in prior literature. But in this data set, what we found was that the longer delays in submitting forms, for every week, that there were delays in submitting the assessment, the reliability of the assessment or the utility of the assessment actually decreases. So when we informed this to our program directors, they actually mandated that within a certain number of weeks or within a certain amount of time, the assessors were required to submit their feedback, because after a certain amount of time, they were doing more of the straight lining of the assessments. So now I will move on into a different type of example. So I've so far talked about workplace-based assessments, but what's also important when we begin assessing at the competency level is to be able to synthesize information that gathers data from multiple assessments. And so one way that we've done this about 10 years ago was to begin trying to synthesize assessments into a smartphone application. In other words, can we develop a learner analytics system? And we were asking this simple question: can we synthesize assessment data through learner analytics systems? One such that where we can synthesize information in real time, because the CCCs need every 6 months, but the learners would prefer getting information in real time. Faculty will want to know in real time where the trainees are, and whether that type of information can also be diagnostic and actionable so that the feedback is meaningful. And one way that we motivated this was, as you can see here, this is data from a single learner. So here you can see in this table, there's a range of different assessments that are used. This is from internal medicine again, but there are about 20 plus assessments in internal medicine that the clinical competency committee in this particular setting use to make decisions. And they're tasked with synthesizing all of this information, and this is an N of 1. Now, if this is just to hypothetically exaggerate the task of the CCC, which I'm sure many of you are familiar with, this is an N of 10. Now, for a large program, or if you're beginning to synthesize data from multiple institutions, this becomes a big data problem. It becomes so difficult, almost impossible for a given faculty or a program to track where a learner is when you have multiple assessments and they need to be mapped to subcompetencies in real time. So this really motivated the need for a learner analytics system, or some kind of a system that better aligns with real-time performance of the learners. So in this paper, what we did was we had this group, we met and we did a mapping of the assessments to different competencies. We weighted, so these are the different lists of assessments. We weighted them, there are 26 assessments. We weighted them by PGY levels. We also combine them in a way that was meaningful for this program. And then at the end, after a year, we were able to build this smartphone application. And as you can see here, just to give you the idea, a learner would be able to open up this application. And as you can see here for this, and everything is mapped to the subcompetency. So for this learner that has lower performance on PBLI2, practice-based learning and improvement, this will be automatically flagged to the learner and also to the faculty mentor so that they can make the changes in real time. And so this was something that was very nice, something that people felt had great utility. Of course, we had to spend time with faculty development, but this was what people found to be useful. Now, empirically, a question that came up was, we synthesized this information, we mapped everything, but is it actually predictive? Is it actually giving us the information that we want for learners? So is there predictive utility in this learner analytics tool? So to our surprise, because we were able to now do this with retrospective data, we found that PGY1 scores were predictive of PGY2 and 3. So earlier performance on the learner analytics system were able to predict struggling learners later on in their training, which was phenomenal for us because we never expected to see this level of information. It may be that they're using this in a way that was meaningful, and we'll probably need to study this further, but this provides some level of assurance in this type of learner analytics system that is based on the science of assessment systems. And of course, we went to further understand what was driving these different principles. I'll move on to another example here, because another key aspect of clinical assessments is narrative comments. And we get this question a lot. are clinical comments useful? How well are they aligned with quantitative information as well? So in this paper, we go into much more detail, but just to give you some ideas of the importance, because the main message here is that narrative assessments can be so important, particularly if you're struggling learners. We try to look at two different questions. One, the assessors are providing quantitative ratings, and they're also providing narrative comments. So are these two different sets of information, are they aligned? And we found, to our surprise, that there was actually moderate to high levels of correlation here. In other words, if the learner had higher levels of quantitative ratings, they're more likely to have also positive narrative comments and vice versa as well. But perhaps what was more important here was the quality of the comments, because some of if you had very high ratings, they would say, excellent job, a resident I'd like to work with, or something that's very short, but it's not really, so it's very positive, and yet in terms of feedback, in terms of whether the information could be diagnostic or actionable, it's really not there. And what we found here was that particularly when the learner was struggling, and this was more so if we look at the lower quartiles of performance, the narrative comments became much more diagnostic and actionable, and we looked at different themes that were very impactful. And these were rotation evaluations, so some of them, of course, had good information, others had less types of information. But there were, the bottom line here is that these comments do tend to have information, and this is an emerging theme that we see across the field as well, in different specialties. There are multiple publications demonstrating really the power of narrative comments when it comes to these types of clinical evaluations. This is the last example. Here, this is a project that I've been doing with the ACGME. And the idea here is to look at learner trajectories. I know that when we all get the annual reports from the ACGME, there are these types of box plots with very linear graphs of how learners progress at the national level. But we know that learner progression may not always be in a linear format. So learners may have linear growth, but then they might improve, have and plateau, or have slower levels of growth and improve. So there could be variations in how learners improve. So this was data that we looked at over 500 programs, over 3,000 learners in family medicine. And this is one sub-competency. And we individually plotted all of their performance from entry to graduation. And as you can see, there's a whole different set of trajectories that you can see here. So it's very hard to see any emerging patterns. And if you're familiar with the reports that the ACGME provides, they typically have a very linear line, as you can see here. So this is the typical line that people provide, a very linear line, but a lot of variability. So this is the 95% confidence intervals of how learners perform from entry to graduation. But there's a technique that we can use to identify unique trajectories, and this is what we did here. I'll skip through all of the details of the methodology, but in the end, what we found was that there were 4 unique trajectories. And this really indicates that there are different patterns of learning for learners, and this is just one subcompetency. And you can find here that level 4 is the graduation target for unsupervised practice. Around 16% never reach this graduation target, and they're lagging here. And what you can see here for this particular group is that there's a blue line and there's a red line. And at the end of year 1 is where they diverge. And when we begin looking at these different types of learner trajectories, we can begin seeing that there are patterns where learners typically tend to diverge. And these are points of remediation that could be quite useful for training and for programmatic purposes. And so this is one of the areas that we've been looking at. We've been doing this at a smaller scale, also in psychiatry, with a smaller number of 20 different programs, also in anesthesiology as well, because we've really found that there are different patterns of growth, and they could be clustered into certain groups that have meaningful implications. These are other examples here. These are for other subcompetencies, but very much the same types of themes that we see. So identifying different patterns of learning trajectories can serve to target and remediate learners who may show signs of difficulty in their training. So now I'll move on into my final implications and summary slide as well. And this slide here is a common slide that you may have seen. It's around goalkeeper science, and it's a theme that many of our colleagues in medical education have been thinking about. And the idea is very straightforward here, where what's the best way to stop a penalty kick? And there were a group of economists that looked at data, retrospective data, for a particular set of penalty kick that soccer players do. And one of the things that they found was that soccer player, the goalkeeper, about 94% of the time would dive to the left or dive to the right, when staying at the center and reflecting would have really saved them from the goal. And so, this really, this analogy of the goalkeeper science, and I really bring this back to the initial slide that I have around the T-steeping model. The T-steeping model and the time-based model, initially when it was proposed, gave many of us a lot of creativity and innovation as we think about new ideas as we transform education. But also there's a lot of good science in assessment that dates back 50, 60 years ago, which is where the goalkeeper science theme resonates. And so I think moving forward, we can begin balancing these two aspects. We want to be innovative, we want to be creative, because we're tasked with developing these new types of assessments that tracks learner performance and competence, but also to be able to balance what we know to be important. My last two slides here just are a summary of the key recommendations that I have from the empirical evidence around maximizing input from faculty, using information from learners, from other health professionals, because gathering that level of data is so important in maximizing the quality of our assessments. Also, aggregating scores improves the precision, as you saw from the reliability aspects. And we can use this type of assessment not only to look at whether learners meet levels of competence or not competent, but really to look at the pathway or their trajectory toward competence, because I think that is where we really have an opportunity as educators to make a difference. These are other sets of guidelines that I have here, but I think synthesizing information from multiple raters, and also a community like ROECSG here could be a nice community where multi-site collaborations and data, and creating an infrastructure where you can share data and think about important assessment questions will be so fundamental to advancing the field and contributing to how we think about assessments. I'll conclude here. Thank you very much again to the ROECSG leadership team and to the members of this conference. Thank you.
That was really phenomenal. There's a whole bunch of questions or comments in the chat basically stating that. So it's incredibly impressive. I think there are a few comments. People are interested in the mobile-based assessment. And then I think Dan had a question that a lot of us would like to hear your commenting on. But do you have any advice for people in terms of the mobile-based assessments and the development?
Yes. So the mobile-based assessment, as you probably saw from the slide, it's not a very fancy tool. So when we began that project, we actually just used Google Sheets, Google Documents, because at that time there weren't any sophisticated vendors who could help us. So many of these brilliant ideas actually came from our learners. These were driven by the trainees because they wanted that level of feedback in real time, and they collaborated with the faculty. And one of the themes nowadays is co-production of assessment, co-production of learning. And I think that was what really made this work. There was a lot of faculty development and a lot of hesitation also because people had to be trained to using this tool as well. But now it was wonderful, and I think it's a mainstream tool that people use nowadays. So I think some collaborative work is wonderful. The other thing I would also say is that building an infrastructure to do educational research, particularly in assessment where you're dealing with assessment data, is fundamental. So spending time to create that infrastructure, a database, for example, creating a research ID, educational research ID, where you de-identify data, but you can use those tools to advance research would be very phenomenal to advancing this line of work.
Great. Anyone feel free to put questions in the chat. One question I have, and Dan kind of comments on a similar topic, but he says, has anyone seen a graduating resident not get all fours from the CCC? And so the kind of corresponding question I have is, what are your thoughts on kind of the pressure that people are given in terms of evaluating learners with the milestones, and how would you best approach that in terms of having them progress through their training?
Yes. So I know that at least from the ACGME side, the milestones are, they're not, the grad level 4 is a graduation target. It's not a requirement. It's up to the individual institutions. When I look at the data, the national data that the ACGME provides, and by the way, ACGME does allow different specialties to have access to the data if you just request this. So we do see a lot of our trainees not reach level 4. And so what do you do with that? Also, at the beginning stages of training at PGY1 level, the first 6 months, there's a lot of variability there as well. And then also in terms of the middle part, there's a lot of variability in the pathway. So I think, mandating these different requirements is one part, but I think also there's a real opportunity now to really study what is going on in this process, in this developmental process of the trainees. Also to think carefully about the types of assessments that they have, the feedback that they have as well.
Thank you. Any other questions?
I unmuted the wrong computer, sorry. I was curious how there was a lot of controversy in our field a few years ago because of how boards were, there was a very low pass rate on the boards. I'm curious what your thoughts are on using certifying exams as kind of the sole means for, board certifying graduating clinicians. One high stakes summative exam rather than maybe reviewing actual cases that the candidate participated in or something like that.
I know that when I attend meetings with the American Board of Medical Specialties, this is an area that the different boards are talking very actively because it's not only the medical knowledge that drives the competence of a physician, but also many of the other important competencies. So I think gradually there's a momentum towards change, but yet I think the reason why they continuously rely on written tests is because it is still perhaps the most robust assessment tool when it comes to the legality aspects of certification and those aspects. But I think the field is changing, so we'll have to see how those aspects will unfold. Of course, as part of training, there are much more opportunities to have diverse set of assessments. And in this presentation, I focus more on the workplace-based assessment because I think that is a key component where we should be driving feedback. And this is an area where it's really remained the same the last 20, 30 years. The workplace written tests, OSCEs, they've really had a lot of advances. Simulation, there's been a lot of advances. Workplace-based assessments have really pretty much stayed the same 20, 30 years. And I think this is a lot of opportunity where the good science of workplace-based assessment needs improvement because that is where we have a lot of opportunity. There was also a comment here as I was just looking at the chat box about how do you motivate your faculty and your colleagues to submit these rotation evaluations. And this is also a very important question that I get. And I don't know if there's a good answer for this, but one way that I found to motivate colleagues is, so at least in my previous institution at Illinois, the participation rate for rotation evaluations were focused on a small subset of colleagues. So you always have a smaller number of educators who are very dedicated in completing this, but others who may be less familiar with the sophistication around the assessments. And so I think you should use them as real partners in driving the quality of assessments. And what we've also done is we've presented these types of evidence as part of grand round presentations, part of departmental meetings, to show them that these types of rotation evaluations are actually making a difference. They're very meaningful, they're discriminating, have good validity evidence. And once people do see that there's science in these assessments, the participation rates, from my experiences, have gone up significantly. And then they'll continue to do so. So I think those are just from my basic personal experiences of how to motivate colleagues to submit and have better quality assessments.
I think we have another question. It says, would it be useful? How would you suggest going about including resident feedback on clinical professional assessments?
Yes, this is also a very important point because, as I've mentioned, some of the there are competencies where the peers are better at measuring some of these competencies. For example, professionalism and communication skills. And we've seen a little bit of variation from specialties to specialty. For example, in surgical specialties, there's a little bit more of a hierarchy. So there's a little bit of a nuanced differences, for example, to different types of specialties. But these types of information for professionalism and for communication skills, I think are pretty much universal. And I think it's so important to gather information from peers and use that as part of feedback. Of course, they'll need it will need to have some buy-in, because if there is some stakes involved, there will need to be some agreement. But I think this is a good direction moving forward. Also to incorporate information from interprofessional healthcare teams as well.
Yeah, that's a great point. Any last quick questions, or else we can give everyone just a couple of minute break and start back at 3:20. Well, I'd just like to say thank you again. This was really phenomenal, and you might be getting some follow-up questions from all of us who would like to take advantage of your expertise. But thanks for joining us.
Thank you so much. Thank you for the invitation.